The content of this podcast reflects the host's views and opinions and does not constitute medical advice. Hello and welcome back to Long COVID MD. I'm your host, Dr. Ziad Khan. I'm a board-certified physician who's been struggling with the symptoms of long COVID since 2020. In this podcast, I share the medical expertise I've applied to my recovery and give updates on my ongoing journey to recovery. Today, I wanted to talk about a recent video I watched. The University of California, San Francisco, also called UCSF, Department of Internal Medicine, shared their recent Grand Rounds meeting, and the topic was long COVID. I wanted to take some time today to translate what was said in that video and at that meeting to you so that you might know what the leaders of long COVID research in the United States are talking about. Grand rounds are regular meetings that most academic institutions hold, often on a weekly basis. Each department hosts its own grand rounds, and at these grand rounds, it's a privilege to be a speaker. Usually someone in the department who is doing really interesting research, or an invited guest who's doing working on something very interesting, will present to the rest of the department their own research and updates on a specific topic. This is a way for academics to bolster their own speaking CVs, but also as a way to educate and update the entire department on a specific topic. We all know that the field of medicine is very, very broad, and a lot of interesting things are happening in corners of that broad world that we may not have access to. So as physicians, we use grand rounds to learn about specific topics or learn what's the latest on specific topics. UCSF Internal Medicine on December 14th, 2023, hosted grand rounds entitled Updates on Long COVID. There were 3 speakers as the panelists. Dr. Ziad al-Aly, who is an epidemiologist and a PhD at Washington University in St. Louis. Dr. Michael Peluso, who is an MD, MHS, who is an infectious disease physician and researcher at UCSF. And Dr. Akiko Iwasaki, who is a PhD immunobiologist at Yale. All of these names might be familiar to you because they have been doing a lot of work and advocacy for patients with long COVID. The host of Grand Rounds, which is often the case, is the department chair, in this case, Dr. Bob Wachter. Grand Rounds are tailored to physicians with a pretty significant science background, and the language that we use in Grand Rounds is often very high-level scientific language. So I listened to the lecture series and I wanted to translate what was said to make it a little bit more easy to understand. I'm going to be paraphrasing each speaker's words and with the most sincere of intentions. And in general, I'm going to be going in chronologic order, but not exclusively. I am going to bounce a little bit just for clarity. In general, Dr. Ziad al-Aly talked about the severity of long COVID, how much of a risk patients who contract COVID-19 have to getting long COVID, and how the disease burden of long COVID compares with the flu. Dr. Peluso talked more about what we know about the clinical presentations of long COVID, what long COVID looks like, some ideas of what might be causing long COVID, and the demographics of patients with long COVID. Dr. Iwasaki talked about her science lab-based research using blood samples, animal models, and machine learning, which I think is AI. The goal of her lab is to develop immune profiles of patients with long COVID to uncover the source of these symptoms. So the first speaker was Dr. Ziad al-Aly, again, an epidemiologist from Washington University in St. Louis, Missouri, United States. Dr. al-Aly discussed several published studies from his own lab that demonstrated that patients who are infected with SARS-CoV-2 are at risk of having symptoms of long COVID for at least 2 years after initial infection. He impressively studied a cohort of 150,000 people with COVID and 11 million controls. He followed them over 2 years and surveyed them for 80 symptoms. He and his team found that patients who were hospitalized with COVID were at higher risk of developing long COVID symptoms than those who were not hospitalized, but that even patients who were not hospitalized at initial infection remained at elevated risk of developing these symptoms for at least 2 years after initial infection. He said that long COVID truly is long. He also talked about the harm of reinfection and stated that reinfection certainly is harmful, whether you have natural immunity from a COVID infection or if you are vaccinated, or both. Patients who were reinfected with SARS-CoV-2 are at increased risk of having problems in several organ systems compared to those with only one infection. The risk of complications after infection is cumulative. So 2 infections is worse than 1, and 3 infections puts you at a higher risk than 2. He said some people wonder if the risk of health complications plateaus after a certain number of infections. Do we get to a point after several infections that we no longer increase our risk of complications? He said we don't know that, but we do know that that plateau does not occur at 3 infections. The bottom line is that reinfection increases risk for health complications across several organ systems for at least 3 infections. He then talked about his research comparing the effects of SARS-CoV-2 versus seasonal influenza or the flu. In 2020, their lab found that COVID infection was 4 to 5 times more fatal than seasonal influenza. In 2023, their data demonstrated that for patients under 65, mortality of COVID and mortality from the flu were equivalent. But mortality remains elevated for patients older than 65 during an acute COVID infection. His team also studied the effect of COVID infection in the post-acute phase by following close to 100,000 patients with either COVID or the flu for 18 months after infection. They surveyed these patients for 94 different health outcomes across organ systems. His team found that the flu causes worse respiratory outcomes and that COVID causes worse outcomes across every other organ system. Dr. al-Aly believes that the flu is a respiratory virus and that SARS-CoV-2 is a multisystemic illness. He notes that the majority of risk occurs during the acute phase for both COVID and the flu, but health risks remain in the post-acute phase. He then talks about their studies on disease burden. Disease burden is a measure of both morbidity and mortality caused by, in this case, a virus. And it reflects not only how many people have died due to the disease, but how the virus has reduced the health of the population. His team found that the disease burden of COVID is greater than that of the flu in the post-acute phase of the disease. So COVID makes a population more ill than the flu, even after the initial phase of infection resolves. These are pretty powerful findings, especially when we hear things like COVID is just the flu, or COVID is the same as the flu, or COVID is the new flu. They are distinct diseases, and I found it particularly powerful when Dr. al-Aly noted the difference in how these viruses affect different organ systems, saying that the flu is a respiratory virus and COVID is a multisystemic illness. Dr. Peluso spoke next. Again, he is an infectious disease clinician, physician, and researcher at UCSF. And he discussed the clinical progress of long COVID in 2023. He reminded the audience that long COVID is the most recently identified infection-associated chronic illness, and we know of others, particularly myalgic encephalomyelitis. Infectious agents that are known to cause, trigger, or be associated with chronic illnesses like this include enteroviruses, Ebola, Giardia, Epstein-Barr virus, and Lyme. Many of these illnesses share similar presentations, which makes us believe there is an underlying mechanism contributing to all of them. Unfortunately, the diagnostics for long COVID have not changed much since last year, and clinicians continue to struggle in diagnosing and managing patients with these conditions. He reminded the audience that the documentation of a positive COVID test is not required for long COVID diagnosis. A presumed infection is also valid. Once a clinician diagnoses a patient with long COVID, we cannot forget to perform the typical age-appropriate screenings for things like cancer and heart disease. Undiagnosed medical conditions might be ignored if we attribute all of it to long COVID. So while specific biomarkers for long COVID are not yet available, many are under investigation, and until then, he referred to some CDC guidelines for working up patients with long COVID. Those included comprehensive but pretty nonspecific lab work. He also referred to a treatment approach published in the British Medical Journal this month, December 2023. For now, symptom management remains a mainstay. Some patients improve with time. Some patients benefit from physical therapy or occupational therapy, but we must be careful since some long COVID patients are harmed by PT and OT by getting post-exertional malaise. He told the audience that patients and clinicians are trying medications for off-label use to help with symptom management, and this is pretty reasonable as long as it's done with care. No single treatment works for all patients, and he emphasized later in the question and answer period that safety is very important. His opinion is that patients should be working with clinicians when they start new medications, and the one treatment strategy that he discourages patients from using very strongly is triple anticoagulation therapy, because in his opinion, the risk-benefit ratio is just not worth it. You can have a catastrophic outcome, he says, with triple anticoagulation therapy, and it's, in his opinion, it's just not safe. Today, long COVID management starts in primary care settings, but he said we really need more specialized long COVID clinics and more funding for these clinics. We also have to remember that we're fighting some negative media attention and stigmatization of this disorder. He said we do have some demographic information that can be helpful when screening patients for long COVID. We know that women are more likely to be diagnosed than men. Older patients are more susceptible than younger patients. The severity of the initial infection and the pre-existing comorbidities of a patient, including diabetes, obesity, and HIV status, does matter in how the patients do once diagnosed and after. He says to note socioeconomic status and access to healthcare. This matters. He says he screens lower income, lower access patients for long COVID because they're often less connected to this news and are not aware that this condition exists. He said we see more cases of long COVID in patients infected with earlier strains. He thinks there are likely genetic and epigenetic factors associated with symptom severity. He notes that Dr. Al-Aly's group, their data showed that prevention of long COVID, the best way to prevent long COVID is to get vaccinated and stay up to date. Vaccines and boosters are clearly protective against long COVID, according to Dr. Ziad al-Aly's data. He notes that there is some data recently that treating acute COVID with Paxlovid may reduce the risk of long COVID or the risk of heart attack in the first 6 months after infection. He explains that there are several models currently being used to understand the root cause of long COVID. These include viral reactivation. So you had a virus in the past, these acute symptoms resolved, the virus did not clear your body, it's actually latent, and this new insult, this new infection has altered your immune system in such a way that the virus becomes active again. Another model is the dysbiosis theory. This refers to the gut microbiome being changed. The gut microbiome is an important factor in the body's immune system. And if the gut flora has been altered, it might make patients susceptible to developing long COVID. Another theory or model being used is the idea of microvascular dysfunction. Another is the idea of autoimmunity. So this might be an autoimmune disease similar to scleroderma or lupus, where The body's immune system recognizes normal tissue as foreign and attacks itself. The last model, and one that Dr. Peluso is especially interested in exploring, is that of viral persistence. His lab found that patients who had a higher viral load during their initial COVID infection and those who shed the virus for a longer period of time were more likely to develop long COVID. He found this by drawing labs on patients with a new COVID infection every day for 3 weeks and studying this blood work for evidence of virus. He then followed up with the patients to see their health status 4 months later. He said the main accomplishment of 2021 and 2022 was demonstrating that vaccination was protective in preventing long COVID. He said in 2023, we discovered that acute antiviral treatment in the first 5 days of infection might reduce the risk of long COVID and heart attack in the 6 months after infection. I don't recall which study he is referring to here, but I'll link the lecture in the show notes. He, as an HIV doctor, said that he initially believed that HIV was different than SARS-CoV-2 in that HIV was a virus that persisted and COVID was transient and did not persist. But this framework has come into question over the past year. He quotes Amy Prowell's recent review that demonstrated that pieces of the virus persisted in patients over weeks when we would assume they would have cleared by then. He also notes a study at Harvard that demonstrated that spike protein could be measured in patients for up to a year after COVID infection in some people with long COVID. His lab collaborated with this Harvard research lab. He sent samples of his patients who were infected with COVID before vaccines were available. So all of the findings in these studies were caused by or associated with the virus and not the vaccine. They found evidence of the SARS-CoV-2 virus in the blood of some patients for up to 14 months post-infection. They also found that this viral persistence was strongly related to the severity of the initial infection. Patients who were hospitalized with COVID were twice as likely to have this finding as those who were not hospitalized. But even among those who were not hospitalized, those who felt the sickest were 4 times as likely to demonstrate evidence of viral persistence as those who reported mild symptoms. He did note, however, that we see evidence of viral persistence in some people who feel totally fine, so certainly more studies need to be done in this sphere. He then discussed areas of clinical progress, which means potential treatments. He talked about a recent Hong Kong study that was blinded and was intended to probe the dysbiosis theory of long COVID. So one group of long COVID patients received a cocktail of pre- and probiotics, which they call a symbiotic cocktail or a symbiotic, and the other group got a placebo. The patient's symptoms were followed using surveys at least before and after treatment. They found a significant improvement across a variety of symptoms in the symbiotic group as compared to the placebo group. The placebo group, however, also had some improvement in symptoms. I actually read this article a few days before I watched this video, Someone had sent it to me. And in that article, there is a clear identification of what the symbiotic was. The problem is I don't know the first place to get it in the US. So the second clinical trial that Dr. Peluso mentioned is his own. He started a study called Outsmart LC, or Outsmart Long COVID. It is a clinical trial studying the utility of monoclonal antibodies. So this treatment is based on the model of viral persistence. So monoclonal antibodies are similar to the antibodies that the human body naturally makes when exposed to a new virus. Antibodies recognize something on the virus and then bind to the virus or part of the virus. This then starts a cascade of events in the body that ultimately leads to the viral particle being eaten up or cleared through the body. The monoclonal antibodies that Dr. Peluso is using have been made in the lab, and they are a strain that can identify many strains of SARS-CoV-2 and then help the patient's bodies destroy viral particles. This study is ongoing. He has enrolled 30 patients, so it's not very big, and results can be expected by the end of 2024. Dr. Peluso ends by making some predictions for 2024 too. So he believes that the RECOVER results will come out. RECOVER was a study that was initiated in the US, funded by the NIH. It was basically funding for labs to study long COVID. I believe that labs who were given funding had to propose a study and then were granted funds. The types of studies that were done in this RECOVER initiative were pretty broad. I don't know that all of them were useful, but Dr. Peluso says that he believes that the RECOVER results are going to inform the research agenda, ongoing research agenda, so we can better understand the pathogenesis of long COVID. He also believes that there's going to be more large-scale collaborative science, and I really hope he's right about that. He thinks there's going to be more of a focus on long COVID as a tissue-based disease, and he notes that a tissue biopsy program is starting at UCSF. He thinks there is going to be a large acceleration in clinical trials in 2024, and again, my fingers are crossed. But he believes that we need more funding for clinical infrastructure to study long COVID. We need more NIH funding in the ongoing RECOVER studies and outside of those studies as well. He says we need more advocacy, and he refers to the long COVID moonshot initiative. The final speaker was Dr. Akiko Iwasaki, who is an immunobiologist, PhD at Yale. Her focus is understanding the immunological basis of long COVID. She spent a little time getting into the weeds of her lab techniques, but in general, she uses patient blood samples and a variety of assays to study them. She uses animal models, and she uses what she calls machine learning, which I believe is AI-enabled software that helps her analyze data and correlate her lab findings to patients' clinical presentations. She seems to want to find a biomarker for long COVID and talks about predictors of long COVID. I think that this means that she takes patient data and enters it into her AI-enabled software. Which data is more likely going to identify a patient with long COVID? which data correlates to clinical presentation of long COVID. What she found was that reduced cortisol levels were a predictor of long COVID. Patients with long COVID tended to have reduced cortisol levels and elevated cytokines. Cytokines are a category of immune cells. Patients with acute COVID infection, she noted, do not tend to show this pattern. It's unique to long COVID patients. Now, cortisol is a hormone that is controlled by several organs in the body. It is ultimately released by the adrenal gland, which sits next to the kidney. But the adrenal gland receives messages from the brain via hormones that controls the release of cortisol, which is also a hormone. So Dr. Iwasaki is studying which part of this pathway is the culprit and causes the reduced cortisol levels. Her machine learning methods also identified patterns in several cells involved in the immune system. It also suggested reactivation of Epstein-Barr virus was involved. She, at this point, mentions that the Petrino lab at Sinai in New York, their studies and data also support this. She has found evidence of SARS-CoV-2 viral persistence, as well as the involvement of herpes virus. She has also found sex-based differences in long COVID patients. Many symptoms are similar across sex, including sleep changes, fatigue, and nausea. Female patients have more pronounced dizziness, body temperature issues, cough, changes in smell, feelings of pins and needles, hair loss, and reactivation of Epstein-Barr virus. They also have reduced testosterone levels, which she said was a hormone predictor of long COVID patients. In males, she found sexual dysfunction more prominent, reduced estradiol, and males and females had sex-specific changes in certain immune modulating cells and antibody levels. She notes that there may be subsets of long COVID patients. When we think about the root cause models that I mentioned earlier, some patients might have several root causes happening at once. Others might have root causes that occur sequentially, so one after the other. And others might have symptoms due just to one cause. She says if we can identify the underlying cause, we can target treatment. And speaking of treatment, she does have one clinical Paxlovid trial, which is ongoing, where she is treating patients with 15 days of Paxlovid to assess improvement of long COVID symptoms. This would be going after the idea of viral persistence or a viral reservoir. She chose 15 days of treatment after collaborating with Pfizer, and apparently they shared some of their data for Paxlovid efficacy and tolerability. She herself thinks a 5-day course after acute infection might not be long enough to optimally help prevent bad outcomes, and perhaps 15 days is too short, she says, to optimally help long COVID, but that's where they're starting with the framework that they have. Currently, 100 patients are enrolled, and the hope is to match the patients who improve with drug intervention to their immune phenotype to better identify which patients will benefit from antiviral treatment. In parallel, she is using several animal models to probe for root causes or for potential root causes of long COVID. One is she's using animal models to study the idea of viral persistence, to study autoimmunity, to study reactivation of gamma herpes virus, and to study the idea of tissue damage or the extent of tissue damage. And for this, she is collaborating with Dr. Michelle Manji at Stanford. In particular, they are studying how a mild respiratory COVID infection could lead to chronic damage in the central nervous system. After Dr. Iwasaki's presentation, Dr. Wachter led a Q&A. The panelists discussed some of the following topics. They talked about metformin. There was talk about metformin helping to prevent severe symptoms or as a treatment of acute COVID. Dr. Wachter asked, should we be using it now? The panel's opinion is that it did show some benefit based on one early study in particular, but that study was done before vaccines were available and before antivirals were available. So we would need new studies to see if metformin benefits patients more than the vaccine or antivirals do. Dr. Wachter asked, what do you suggest for treatment of long COVID since there's nothing evidence-based? And unfortunately, there wasn't a lot that was helpful in the answers here. The panelists, the only clinician was Dr. Peluso, but of course, all of these scientists have insight into what the long COVID community has been trying. They suggested symptom management certainly helps tolerate long COVID until a more definite treatment comes to pass. Dr. Iwasaki referenced patient crowdsourcing, and she says she refers patients to long COVID communities. Dr. Peluso's advice was that it is perfectly fine to try meds for off-label use, but to do so safely and discourage patients from trying to treat themselves without the collaboration of a clinician. Dr. Wachter asked about boosters. Should we get vaccine boosters? All of the panelists agreed that yes, boosters, you should get boosters as it's preventive against severe COVID infection and therefore preventive against long COVID. Ultimately, Dr. Wachter asked, are you still taking COVID precautions? Do you still mask? All the panelists said they are all they all take COVID precautions. They all mask because they do not want long COVID, and long COVID is a big driver for them to continue COVID precautions. Dr. Iwasaki in particular noted that in addition to masking, preventions like air purification only add to the benefit of prevention. That brings us to the end of this summary of UCSF's Grand Rounds and update on long COVID. I hope you found it useful. I think there's still a really long way to go, unfortunately, but I'm really happy to see really smart people motivated and excited about furthering their research. It was also really nice to see that we have accomplished something. I think it needs to be faster and we need more of it. What do you think? Email me at longcovidmd@gmail.com. Thank you for listening to Long COVID MD. I'm your host, Dr. Ziad Al-Aly. Until next time, I hope you're doing well today, and bye for now.